Hello and welcome to the topic Disseminated Intravascular Coagulation in the Haematology module. By the end of this topic, you should be able to define Disseminated Intravascular Coagulation or DIVC, explain the pathophysiology of DIVC, outline the causes and classification of DIVC, describe the clinical manifestations, outline the investigations done, discuss the principles of management, and discuss the complications and prognosis of DIVC. Let's get started. DIVC is a serious life-threatening condition where there is systemic activation of blood coagulation, and this subsequently results in generation and deposition of fibrin, leading to microvascular thrombi in various organs and contributing to multiple organ dysfunction syndrome. Blood coagulation is an integrated series of hemostatic reactions involving plasma, platelets, and vascular components. Platelets adhere to damaged endothelium or to subendothelium under the influence of adhesive proteins, and when they are activated, they aggregate and expose binding sites for coagulation factors. Platelets therefore act as vehicles to concentrate and potentiate coagulation reactions on the damaged vessels. Following interaction of the contact factors of 12 and 11, the coagulation protease zymogens undergo sequential activation, resulting in the generation of thrombin, the conversion of fibrinogen to fibrin, and the formation of a platelet fibrin hemostatic plug. Then we have fibrinolytic system that interacts to regulate fibrin deposition and removal during healing. Central to coagulation is the generation of thrombin. It is involved in promoting hemostatic reactions as well as a number of protective functions. The activities of thrombin and the other serine proteases are modulated by serine protease inhibitors, including antithrombin 3 and heparin cofactor 2, which are important in regulating the physiological anticoagulant action of glycosaminoglycans at the endothelium. So there are four simultaneous mechanisms that occur in DIVC, which are thrombin generation and tissue factors, impaired coagulation inhibition system, defective fibrinolysis, and inflammatory activation. In thrombin generation and tissue factor, exposure to tissue factor in the circulation occurs if endothelial disruption, tissue damage, inflammatory or tumor cell expression of procoagulant molecules occur. Tissue factor then activates coagulation via the extrinsic pathway involving factor 7A. Tissue factor 7A complex activates thrombin, which cleaves fibrinogen to fibrin and causes platelet aggregation. Thrombin produced by the tissue factor and factor 7 pathway amplifies clotting and inflammation through platelet activation. Activation of factors 8, 5, and 11 enhanced activation of pro-inflammatory factors via protease-activated receptors. Activation of factor 13 to factor 13A, which augments production to fibrin clots from fibrinogen. And this activates thrombin-activatable fibrinolysis inhibitor, making clots resistant to fibrinolysis and enhanced expression of adhesion molecules, thereby promoting the inflammatory effects of white blood cells. In impaired coagulation inhibition systems, the compensatory mechanisms are overwhelmed once intravascular coagulation commences. Antithrombins are markedly reduced in patients with DIVC, and this is due to continuous consumption of antithrombin secondary to ongoing coagulation. Furthermore, elastase produced by activated neutrophils also degrade antithrombin as well as other proteins, which lead to even lower levels of antithrombin. Further, antithrombin is lost due to capillary leakage. Do note that antithrombin is produced in the liver and liver damage secondary from underperfusion and microvascular coagulation and can again lead to impaired production of antithrombin. In defective fibrinolysis, experimental bacteremia and endotoxemia result in a rapid increase in fibrinolytic activity, most probably caused by the release of plasminogen activator from endothelial cells. However, this pro-fibrinolytic response is almost immediately followed by suppression of fibrinolytic activity due to a sustained increase in plasma levels of PAI1, and these effects are mediated by TNF2 and IL-1. Lastly is the inflammatory activation. So there is cross-communication between inflammation and coagulation pathways. Inflammation gives rise to activation of the clotting cascade, and the resultant coagulation stimulates more vigorous inflammatory activity. Activated coagulation factors produced in DIVC contribute to the propagation of inflammation by stimulating endothelial cell release of pro-inflammatory cytokines and factor 10A, thrombin, and tissue factor with factor 7A complex elicit pro-inflammatory action. With the depression of anticoagulants such as activated protein C and antithrombin further contribute to dysregulation of the inflammation. Now, causes can be divided into acute and chronic in origin. For acute causes include infection, malignancy, obstetrics, trauma, transfusion, and others, which we will further elaborate. First, for infection, it can be due to bacterial, such as gram-negative sepsis, gram-positive infections, rickettsial for viral, and it can be due to HIV, cytomegalovirus, varicella zoster virus, and hepatitis. For fungal, there is histoplasma, and lastly, parasitic. The example is malaria. The next acute cause is malignancy and can be hematological malignancy such as acute myeloid leukemia or metastasis in origin, for instance, mucin-secreting adenocarcinoma. For obstetric-wise, amniotic fluid embolism, abruptio placenta, acute peripartum hemorrhage, preeclampsia, eclampsia, HELP syndrome, retained stillbirth, septic abortion, intrauterine infection, and acute fatty liver of pregnancy are the causes. Then we have trauma, which comprises burn, motor vehicle accidents, and scale envenomation. Do note that DIVC can happen in transfusion as well if there is hemolytic reaction. Other remaining acute causes include prosthetic devices, shunts, and ventricular assist devices. For chronic causes include malignancy, obstetric hematology, vascular, cardiovascular, inflammatory, and localized causes. First, for malignancy, it includes solid tumors and leukemia. The next chronic cause is obstetric, and it can be due to retained dead fetus syndrome or retained products of conception. For hematological causes, it includes myeloproliferative syndromes. For vascular-wise, we have rheumatoid arthritis and Raynaud's disease. Myocardial infarction can lead to DIVC as well. Then we have inflammatory causes which include ulcerative colitis, Crohn's disease, and sarcoidosis. And lastly, localized cause comprise aortic aneurysms, giant hemangioma, and acute renal allograft rejection. Now let's move on to the classification. DIVC can be classified into DIVC with suppressed fibrinolysis, DIVC with enhanced fibrinolysis, and DIVC with balanced fibrinolysis. In DIVC with suppressed fibrinolysis, it is seen in sepsis because fibrinolytic inhibitory factor is markedly increased. Fibrinolysis is suppressed, and dissolution of multiple microthrombi is more difficult, and as a result of microcirculatory impairment, severe organ dysfunction may occur, but bleeding complications are relatively mild. As for DIVC with enhanced fibrinolysis, it is seen in APML, abdominal aortic aneurysm, and prostate cancer. Fibrinolysis is strongly activated with hardly any elevation in PAI, which is the fibrinolytic inhibitory factor. The bleeding symptoms tend to be severe, however, organ dysfunction seldom occurs. And lastly, in the case of DIVC with balanced fibrinolysis, which is seen in solid cancers, it may progress to DIVC with enhanced fibrinolysis in some cancers, such as prostate cancer and vascular malignancies. Symptoms are often those of underlying condition, so local presentation is usually pain, which can be due to snake bite, infected ulcer, or polytrauma. For systemic presentation, patients could experience fever, bleeding, or abdominal pain, which can be due to pancreatitis, abdominal aortic aneurysm, or abruptio placenta. Signs also depend on the underlying conditions. For local signs, patient can have bleeding into serous cavities, respiratory signs such as pleural friction rub, and signs of ARDS, gastrointestinal signs such as hematemesis and hematoxesia, genitourinary signs such as azotemia, renal failure, acidosis, hematuria, oliguria, menorrhagia, and uterine hemorrhage. Dermatological signs include skin necrosis, gangrene, and wound bleeding. For systemic-wise, patients can present with petechia on soft palate, trunk, extremities, or venipuncture sites. Ecchymosis on traumatized area, then they can also have signs of hemorrhage and signs of shock such as hypotension, tachycardia, and circulatory collapse. Not to forget jaundice, which can be one of the presentations as well. Additional signs include bleeding from at least 3 unrelated sites: renal failure, hepatic failure, respiratory failure, shock, and central nervous system dysfunction, which could include coma, obtunded mental status, and paresthesia. When it comes to investigations, first order a D-dimer where a value above the upper limit of normal is considered moderately elevated. A value above 5 times the upper limit is a strong increase. ISTH scoring, or International Society of Thrombosis and Hemostasis, can be used. Proceed by using this algorithm if patients have an underlying disorder known to be associated with overt DIVC. Then integrate with global coagulation tests including platelet count, prothrombin time, fibrinogen, soluble fibrin monomers, or fibrin degradation products. Based on the result, if the score is 5 or above, it indicates an overt DIVC, whereas a score of less than 5 does not rule out DIVC but may indicate that DIVC is not overt, and to repeat the test in next 1 to 2 days. As mentioned, global coagulation tests, which include platelet count, fibrinogen concentration, and PT, can be ordered. You can expect a low count due to consumption, decreased fibrinogen concentration as fibrinogen cleaves to fibrin, and a prolonged PT due to consumption of coagulation factors. D-dimers, which is a product of fibrin breakdown, can be used to differentiate DIVC from other conditions such as chronic liver disease, where there is low platelets with prolonged clotting time. Next up, imaging, which should be used as well in order to detect the underlying cause. Platelet counts are used to diagnose DIVC. It can also be used to look at the trend values for the drop from previous level, and for prothrombin time, it can be used to monitor the progress of DIVC. For management via medical therapy, the aim for patients with acute DIVC but with low bleeding risk is to treat the underlying disorder. For patients with acute DIVC but with high bleeding risk or active bleeding, the underlying disorder should be treated well, but at the same time is to manage the bleeding by platelet transfusion when platelet counts are less than 20 of 10 to the power of 3 microliters, or 50 or less than 50 times 10 to the power of 3 microliter with active bleeding. Fresh frozen plasma is the preferred agent when significant bleeding is present, or when fibrinogen levels are less than 100 mg per deciliter, and cryoprecipitates or fibrinogen concentrates as second-line alternatives. Please beware of blood-borne diseases such as hepatitis, HIV, CME, and syphilis, and febrile reaction. Besides that, rapid infusion of platelets, FFP, and cryoprecipitates fibrinogen concentrate may cause hypotension. For chronic DIVC, treat the underlying disorder. In patients with chronic DIVC with suppressed fibrinolysis, heparin can be used. For patients with dominant symptoms and signs of thrombosis without evidence of significant bleeding. For patients with chronic DIVC with enhanced fibrinolysis, antifibrinolytic agents can be prescribed. The primary option is aminocaproic acid, and second option is tranexamic acid. Now, let's look at the complications. The complications for DIVC are acute renal failure, life-threatening hemorrhage, cardiac tamponade, hemothorax, intracerebral hematoma, and loss of digits or gangrene. The prognosis for patients with DIVC is poor with high mortality. Study has found that the mortality rate is as high as 59% compared to 14% for patients without DIVC with the same underlying disorder. So in summary, DIVC is a serious life-threatening condition characterized by systemic activation of blood coagulation, where there are 4 simultaneous mechanisms that occur, which are thrombin generation and tissue factor, impaired coagulation inhibition system, defective fibrinolysis, and inflammatory activation. The causes can be divided into acute and chronic. For acute causes include infection, malignancy, obstetrics, trauma, transfusion, while chronic causes include malignancy, obstetrics, hematology, vascular, cardiovascular, inflammatory, and localized causes. Signs and symptoms depend on the underlying disorder, and do note that most of the patients can bleed at least from 3 unrelated sites. For investigations, order a platelet count, hematological investigation, fibrinogen count. The aim of the management is always to treat the underlying disorder and then platelet transfusion if platelets are low or with active bleeding, cryoprecipitate or fibrinogen concentrate as second line. Heparin and antifibrinolytic agents can be used for chronic DIVC cases. We have come to the end of this topic. Thank you.